What I would like to do in the next 30 minutes, ladies and gentlemen, is to take you through 60 years, except I'm going to take the first 15 minutes to go through about 50 years, 55 years, and the last 15 minutes to go through the last 5 years, because over the last 5 years, we've had some very, very interesting papers come out in this field. And what I wanted to do is to share them with you and sort of put everything into a context as to where we are. Now, obviously, diet has an impact on lipoproteins. And what we're trying to do, of course, is to correct the lipoproteins. We want to lower total cholesterol. We want to raise HDL cholesterol. We want to lower LDL cholesterol. But there are many components in the diet that have an impact. And we've heard about antioxidants at this meeting, and what I'm going to focus on for my talk is the role of dietary fat. Dietary fat, there are many, many sources of fat in the diet. And this is just a schematic of the various fats and oils that are out there in relation to their fatty acid composition. And the main point here is that there is no single fat which is exclusively saturated, monounsaturated, or polyunsaturated fat. So when we talk about a saturated fat or a monounsaturated fat, you have to bear that in mind, that that's just based on a physical property that we may find at room temperature. Palm oil is sort of unique in that it's right in the middle in relation to its saturated and unsaturated content being equally split between the saturates and the unsaturates. The unsaturated fatty acids are desirable from a nutritional perspective. We need the PUFAs in the diet. But from a functional perspective, the unsaturated fatty acids create headaches. So what we want then is saturated fatty acids from a functional perspective. And they create headaches to the consumer because we've been telling the consumer one thing for the last 50, 60 years, and we keep changing it, and we keep changing it, and we keep revisiting it, as I'm going to be doing again this time around. So if we want to look at what fat does to cholesterol, we have to start at the beginning. And back in the late 50s, these classic equations were published from Hegsted and Keyes group, which essentially said that serum cholesterol, you could predict that based on the content of the saturated and the polyunsaturated fatty acids, with saturates raising cholesterol and polyunsaturates lowering it. And essentially over the years, those equations were modified, worked on, fine-tuned by other workers, but essentially the original findings held that saturates raise serum cholesterol and polyunsaturates lower it. So of course the simple message became that we need to replace saturates with unsaturates. Well, that's not that straightforward, because when we're talking about serum cholesterol, which is what these initial studies looked at, that doesn't tell you anything about the individual lipoproteins. And we know there are underlying differences. LDL cholesterol is a risk factor. It raises risk. HDL is protective. So what you really want to look at is the ratio of LDL to HDL cholesterol, or, as what most clinicians do, the total cholesterol to HDL cholesterol ratio, which, based on the American Heart Association current guidelines, we should be aiming for a ratio less than 4. So what are the effects of fatty acid classes on lipoprotein cholesterol? In other words, what do they do to LDL, HDL, and the ratio? Now, if you want to look at fatty acids, you have to have some sort of comparison. There's no point comparing them to each other because one will always look better than the other. So you go and look at fatty acids in relation to an equivalent amount of calories from carbohydrate. So this figure shows what happens if you replace 1% of calories from carbohydrate with saturates, cis monounsaturates, polyunsaturates, or trans fatty acids. And we can see that the mono and the polys lower LDL cholesterol. So if your endpoint is LDL cholesterol, you say, okay, great, mono and polys are the best, saturates and trans are bad. Well, when I was younger, we did a series of studies when I was doing my postdoc, and we came out with something called the threshold hypothesis. And that was sort of in part what Dr. Clarendon talked about when he was talking about looking at palmitic acid in relation to the level of linoleic acid. And what we essentially showed way back was that myristic and linoleic acid are key factors in this. Myristic acid raises cholesterol and linoleic acid lowers it, but linoleic lowering reaches a threshold, and that's around 5 to 6% of calories. And palmitic is important in relation to the linoleic acid content, and also the receptor activity of your LDL receptors. We did more extensive analysis in gerbils, more than 50 diets were looked at, and again, we basically showed the same thing. And we found a similar story in hamsters. So the problem all these studies suggested was it may not be the presence of saturated fatty acids per se. Perhaps it's the absence of PUFA. And as Dr. Abby Wardana said, it's not necessarily what's in the diet. It could be what's missing. You have to be looking at various interaction. So this LDL story sort of evolved from there. Okay, so if you stop at LDL, you get one answer. But if you look at HDL, and HDL is beneficial, then all of the fatty acid classes raise HDL cholesterol, with the exception of trans. So now, of course, if you compare trans to one of those fatty acids, trans is HDL lowering. Put them two together and look at the ratio of total cholesterol to HDL cholesterol. So monos and polys are the best. Now, this is in relation to carbohydrate. Trans are the worst, and saturated fatty acids don't do anything. So if you're taking out saturates at the expense of carbohydrate, nothing is going to happen, except we're going to see in a few minutes that it will depend on the type of carbohydrate. All right? But that's looking at classes of fatty acids. We know that amongst the saturated fatty acid, we have differences. So we've got lauric and myristic acid-rich coconut oil, and we've got palm oil, which has got palmitic acid. So what do the individual saturated fatty acids do using the same sort of analysis? So if we look at individual saturated fatty acids in relation to carbohydrates, so we have lauric, myristic, palmitic, and stearic. Lauric, myristic, and palmitic raise LDL cholesterol. Stearic has no effect. Those saturates raise HDL cholesterol. Stearic has no effect. And when we look at the ratio of total cholesterol to HDL cholesterol, we now see that the improvement in the ratio is with lauric acid. And this has sort of been a resurgence in the last 4 or 5 years, and people have started looking at coconut oil, again, based on what lauric acid is doing. So lauric acid is improving the ratio. Palmitic acid, the major saturate in palm oil, again, is having no effect. So relative to carbohydrate, and based on lipoproteins, it appears that saturates are not doing anything per se. It's the unsaturates which are causing shifts, and the trans which are causing adverse shifts. So where does that put us in relation to palm oil? Just based on the total cholesterol to HDL cholesterol ratio. So there's been about 7 or 8 studies which have directly compared feeding palmolene with various other vegetable oils in human population. And in this figure, which is a summary from 6 studies, what we're looking at is the effect in humans on the total cholesterol to HDL cholesterol ratio of feeding palm oil, shown in orange, against olive oil in red, and canola in light blue. And as you can see, head on, palm oil and olive oil, palm oil and canola are exactly the same in this population when you're looking at the total cholesterol to HDL cholesterol ratio, which, as far as I'm concerned, is case closed just based on that point. Now, what about trans fatty acids? Because we've said in the previous analysis that trans fatty acids have the worst effect on the total cholesterol to HDL cholesterol ratio. Well, the trans that we're talking about are the ones that are produced by partial hydrogenation, whereas full hydrogenation will give you saturated fatty acids, and invariably it will give you stearic acid. And stearic acid, based on the lipoprotein analysis, is neutral. So trans fatty acids result from partial hydrogenation, whereas saturates come from full hydrogenation. In 1997, during my postdoc days, we did a series of studies directly comparing saturate versus trans. In this case, the comparison was palmitic acid, a palmitic acid-enriched diet with a diet enriched in alaitic acid, which was produced by partial hydrogenation. And this is a study in non-human primates. This was in cebus monkeys. And as you can see in the first panel on the left, the red is the animals when they have been fed palmitic, and the yellow is the animals when they've been fed the trans, and that's looking at HDL cholesterol. So trans lowered HDL cholesterol relative to palmitic acid in all these animals. This resulted in an increase in the total cholesterol to HDL cholesterol ratio with trans, and mechanistically, this was attributed to an increase in cholesterol ester transfer protein. And cholesterol ester transfer protein is the current target for drug design. There are various phase 3 clinical trials going on testing CETP inhibitors in humans. The idea being that if those trials work, CETP inhibitors will then be in the market, and their job is to raise HDL cholesterol. And this data from monkeys has been verified many times in humans. So that was the mechanism. And from this data, it's clear that saturates and trans are different. All right, so by that time, the message became, all right, replace trans and saturates with MUFAs and PUFAs. But life is not just about LDL cholesterol or HDL cholesterol, which is what we've been discussing so far. There are many, many things that go into heart disease and atherosclerosis, not just the plasma lipids. That's just a biomarker. There are other parameters we have to pay attention to. And what are some of those parameters? Well, one thing is the size of the LDL. Small LDL, small dense LDL, are more atherogenic than large buoyant LDL. And in a study from Ron Krause's group in 1984, here's a scenario in humans where they're going from a diet with 6% of calories from saturated fat to a diet with 18% of calories from saturated fat. And increasing saturated fat decreases small LDL, or it increases large LDL. So even though you may be impacting LDL with saturated fat, you're impacting the large LDL, which are not atherogenic. And those of you who were at the dinner forum last night would have heard Dr. Sundaram present data regarding the Malaysian population, where they've done some initial characterization looking at LDL particles, and it turns out that habitually consuming palm oil for 20 years is associated with large LDL, not small LDL. So they are not atherogenic. So increasing saturates has a beneficial effect on lipoprotein particle size. Similar sort of analysis, increasing saturated fat, again going from 6% of calories, actually going from 3.5% of calories on the left, all the way up to 16% of calories. Now those numbers are important because most recommendations say less than 10% of calories from saturated fat. And what is this figure showing is that as you increase saturated fat from 3.5% of calories all the way up to 16%, narrowing of the coronary arteries slows down. As atherosclerosis progresses, your arteries get narrower and narrower and narrower. And this data is saying you feed saturated fat and you slow down that progression. So another step looking beyond LDL, and it's saying saturates is not an issue. Here's another one, which came out in 1997. This is from the USDA in Beltsville, Maryland, where they were looking at various fatty acids on plasma lipids, effects in humans, and one of the things they measured was lipoprotein little a. Now, lipoprotein little a is an independent risk factor for heart disease. The higher the LP little a, the greater your chance of a heart attack. And LP little a is genetically very high in Southeast Asians. And this study clearly shows that the lowest LP little a is found with feeding saturated fat. And you can compare that to oleic or trans. So something else that says that saturated fat is not what we think it is. So we're still talking replace trans and saturates with monos and polys, and this is the parallel public health messages that are around at the time. So clearly it's not that straightforward because there are nuggets in the literature that you have to look for. So this field took a shift around 5-6 years ago, and one of the shifts was this study, which came out in 2009, and basically what they said that let's look at what happens if you replace the worst fatty acid from the diet, which is trans fatty acid. Now you can't just take trans out of the diet. What you have to do is remove partially hydrogenated vegetable oils and replace it with different fats. However, in this analysis, Mozaffarian and Clark didn't just look at LDL. They looked at the impact based on the ratio of total cholesterol to HDL, based on the impact on Lp(a), based on the impact on C-reactive protein, as well as ApoA1, which is a measure of the number of HDL particles, and ApoB, the number of LDL particles. And they took this analysis and they said, what would happen to CHD if we replaced specific amounts of trans fatty acids in the diet? And that figure is actually pretty clear-cut. Take out trans. That's the message. They're the worst ones. Take them out. And it doesn't matter what you replace them with. You will see an improvement. So if you replace 20% of trans fatty acids from the diet, or 35%, or 45%, and let's say you did it with palm oil, that's the improvement in CHD. And this is based on randomized control trials. So what this clearly establishes is that fatty acids in these different oils and fats, if you look at all the parameters that are impacted, trans are the worst, and if you take them out, things improve. And same thing if you look at CHD events in various observational studies. Okay, so what about impact of fats on CHD risk? Well, here's analysis from the Nurses' Health Study, looking at replacing 5% of calories from carbohydrates with an equivalent amount of saturated fatty acids, monos, polys, and trans. Left bars are effect on CHD, right bars are effect on diabetes. And we can see if you replace carbohydrates with sats, there's an increase. Monos and polys, no effect. Since palm oil is a 50-50 mix of saturates and monos, that means these two would cancel out. So if you're replacing carbohydrates with palm oil, you're not going to see any effect. The biggest improvement is with polyunsaturates. Monos seem to be doing not much. And the most adverse effect is with trans, and here we're talking about only 2% of calories. The other fatty acids, we're looking at 5% of calories. Here we're talking about 2% of calories. So again, it emphasizes the negative impact of trans. 20-year follow-up data, and Dr. Sundar referred to this as well yesterday. Let's just focus on the saturated fat. So this is 20-year follow-up data from the Nurses' Health Study looking at CHD risk in going from 12 all the way up to 18% of calories from saturated fatty acids, replacing carbohydrate. And remember, guidelines talk about less than 10% of calories from saturates. You go from 12 to 18% and nothing. 20-year follow-up, CHD. So we have to go beyond lipids. The only thing you see anything for is PUFAs, and you see adverse effects with trans, again, at very, very low levels of intake, 1.6 to 3% of calories. Okay, in 2009, the World Health Organization convened a panel, and part of that panel, their job was to look at the impact of fat on CHD, and Murray Skeef in New Zealand wrote a review article in which they did a meta-analysis. So we're now in the last 10, 15 minutes, and we're going to focus on the last 4 years. So they did a meta-analysis of many, many cohort studies with large numbers of CHD deaths, large numbers of participants, large number of follow-up years. And when they compared low saturated fat intake, that's 7 to 11% of total calories, to high saturated fat intake, they found no association with CHD. Mortality or events. Also, if they looked at 5% energy increment, so you're replacing fatty acids in 5% calorie blocks, again, there was no association with CHD mortality. Now, obviously, we can't argue with the number of subjects or the number of events because this is large. And this is saying there's actually no association. 2009 from Denmark, Marianne Jacobsen, a pooled analysis of 11 studies, 4 to 10-year follow-up, 340,000 plus subjects, again, a large number of coronary events. A 5% lower energy intake from saturates was beneficial only if you replaced it with PUFAs. And that's a huge nutritional shift. If you wanted to make that shift in the diet, in some cultures you could not achieve that. But theoretically, yes, you replace 5% of calories from saturates with 5% of calories from PUFA, and you saw a benefit. With carbohydrates, you saw nothing. What have most people been doing over the last 50 years? We told them to take out fat. They took out fat. They replaced it with carbohydrates. And so they would have been better off not doing anything based on this analysis. If you replaced 5% of energy from saturates with MUFAs, nothing happened. And yet people have been gung-ho about monounsaturates and olive oil. Yet the data says that monos may not be doing anything. So overall, what did this study show? A significant inverse association between substitution of PUFA and CHD, and a significant direct association between substitution of carbohydrates and risk of coronary events. So now where we're entering is replacing saturates may not be a problem. However, if you do replace them, you have to be careful what you replace them with, because you may only get benefits in certain instances. So they followed this up, and this is a busy slide, but you just have to follow 3 key points. So if you're replacing saturated fat with carbohydrate, if you replace it with low GI value carbs, you will see a benefit, not if it's medium GI carbs. And if you replace it with high GI carbs, you know, soft drinks, for example, refined carbohydrates, you will actually increase risk. So CHD risk will go up if you take out saturates and replace it with refined carbohydrates. Mozaffarian took this one step further in their analysis in 2010 in lipids. So they looked at all the data, and they said, let's see what would happen if we replace saturates with different types of fatty acids based on the different types of evidence. So if you base everything on just the total cholesterol to HDL cholesterol ratio, randomized control trials or observational studies, if you replace PUFAs instead of saturates, you see benefits. If it's carbohydrate replacing saturates, no effect based on lipoproteins, no effect based on randomized controlled trials, and those cohort studies are showing a detrimental effect. And if it's monos replacing sats, this is the interesting one. Yes, based on lipoproteins, you'll see a beneficial effect. There are no randomized clinical trials, believe it or not. Nobody's actually looked at monos versus sats. And then if you look at the cohort studies, that's actually showing a huge variation, but monos may be detrimental. Obviously, that is still to be resolved. We don't know that one. All right, I want to skip that one for time. Ron Krause's group in 2010 in the United States, working out of Berkeley, came out with this one, and this study also created a big stir in the news. Again, 5 to 23-year follow-up. Saturated fat intake not associated with CHD, not associated with stroke, not associated with cardiovascular disease. So you can see that after 45, 50 years, the data has shifted to actually looking at endpoints, not just LDL. As somebody said, in the US, we are LDL-centric, whereas Europe tends to focus more on the ratio of total to HDL. But regardless, one should be looking at hardcore endpoints. And now that we're doing that, we're seeing something completely different. So no associations with CHD, stroke, or cardiovascular disease. And that's just the backup for that. Now, one other interesting facet has been this message from the last 50 years that polys are good for you because they lower LDL. Does that actually translate into decreased CHD? The Nurses' Health Study suggests that, but since 2011, there have been 2 studies, and one of them just came out earlier this year. This is from Hibbelin and Ramsden, and they've actually done something interesting in that they went back and looked at data from a study that was completed in 1966, 1970, which was the Sydney Heart Study, where essentially people were told to replace saturates from the diet with polyunsaturates, and they did a 1-year follow-up. So what happened in this study was that over that 1-year period, those 2 groups, the control group, they carried on with their normal diet for that 1 year, and it just so happened over a year, their saturates hardly changed, neither did their polys, and neither did the cholesterol. That's over a 1-year period. The intervention group that was told to take out saturates, well, they did that, so they decreased their saturate intake by 7% of calories. They were told to replace it with polys. They did that. So their PUFA intake went up 9% of calories, and they were told to take out dietary cholesterol, which they did. Their lipids improved, but when they analyzed the endpoints, completely different results. Namely, if you look at, this is the intervention group in all cases. Oops. The line in blue, there is basically increased risk of all-cause cardiovascular disease and CHD mortality in the ones who took out saturates and replaced it with PUFAs. Now, of course, this is one analysis, one study. A lot of arguments, a lot of discussion already as to why they're finding this. But this is simply suggesting that we need to get away from focusing on LDL and HDL. When we start to look at hardcore endpoints, this is what we're finding. And as my old mentor, David Krzyzewski, used to say, if you torture the data long enough, it will confess. And maybe we are at that point. So all of these studies are showing that saturates not associated with CHD mortality, CHD, stroke, or cardiovascular disease. Now we're talking 300,000, 400,000 subjects. If you use substitution models, basically if you take out saturates, if you replace them with low GI carbs, you get a benefit. Medium GI carbs, no benefit. High GI carbs, it will be problematic. If you replace them with PUFAs, it can be a problem if it's N6, N3 mix, maybe not so. If you're going to go with the low GI carb route, go with complex carbohydrates. Results from prospective cohort studies suggest no effective saturated fat on diabetes. I didn't show you that, but that data is also there. When it comes to removing dietary trans fatty acids, if you remove partially hydrogenated vegetable oil, that decreases CHD risk, and that's based on many different parameters, not just LDL and HDL. Now, since we've got 2 minutes, last time, I know you want to take away a visual. Let's summarize all this. So there's 2 visuals I have for you. This is one. Take whichever one you prefer. So this is from that Skeef and Miller analysis for the WHO. They're looking at total fat, trans, replacing carbohydrates with saturates, replacing saturates with mono, etc. Looking at fatal CHD and CHD events. What do these symbols mean? When it comes to total fat in relation to fatal CHD, we have convincing evidence that there is no relationship. So total fat is not in the picture. When it comes to CHD events, we have convincing evidence that there's no relationship. For trans fatty acids, fatal CHD, we have very strong probable evidence that there is an adverse effect. And for CHD events, we have convincing evidence for an adverse effect. If you replace carbohydrates with saturates, no relationship. We have probable evidence. CHD events, no relationship, probable evidence. If you substitute saturates with PUFAs, but you have to specify which PUFA, there's convincing evidence for a beneficial effect, both in fatal CHD and CHD events. For linoleic acid itself, can't say anything. Alpha-linolenic, can't say anything. Long-chain PUFAs, probable evidence for a beneficial effect on fatal CHD, and convincing evidence for a beneficial effect on CHD events. So that's one visual. Take which one of you like. The other one that I like is from Dario Mozaffarian, and this is also now published, so you can actually go and find this figure in a couple of his recent publications. Looking at fatty acids on CVD, if you weigh up the evidence, benefit, harm, let's go from down. Most harmful is trans fats of industrial origin, and then refined carbohydrates. Most beneficial effects from the top, fish oil, N3 PUFAs, plant-based N3 PUFAs, plant-based N6 PUFAs and MUFAs, and in the middle, saturated fat. Not beneficial, not detrimental, it's sort of in there. We've been focusing on it for 50 years, but perhaps we shouldn't. So I guess, what does it mean? I'm in Malaysia. I'm sure somebody will say, you're standing on a platform, of course you're going to say something. Well, you have to look at the data. And then I guess, it depends on your point of view. Thanks very much.